I like the GORE because there's certain characteristic of the GORE. The first one is the flexibility, the softness of that device, able to conform to the anatomy that we're dealing with. And then also the feature of there's no reported erosion is very important in that way. So when we evaluate patient with a very complex or out of ordinary PFO, long rigid tunnel, it's important because this GORE device has the ability for me to manipulate the device without afraid that it's going to cause harm to the patients or to the anatomy. And we always been taught, don't fight the anatomy, you need to understand that. And knowing that ability to manipulate the device, it makes me able to really have a good result from this device, good sealing, and also the future, the nickel is still an issue in real life. So in specifically in a long tunnel rigid PFOs, we have to have the ability to manipulate the device to across this challenging anatomy. So GORE has that ability because it's flexible. So when you try to deploy the device, which I can show in some of the cases later, you have the comfort that is not going to tint the septum, causing malappositions of the closure, and you can really seal it. There's certain technique that you need to understand to use this device, but it's a lot user-friendly in my opinion. So when we look at a certain anatomy, especially a long tunnel, there are certain features that I look in the anatomy. The thickness of the septum, how long is the septum itself. So the pan-foraminal valley evaluations and using a GORE CARDIOFORM Occluder or GSO can be deployed properly and efficiently. So because those features will determine how we're going to manipulate and maneuver the catheter to go up and then deploy the device. So it's very important to know the anatomy, your intracardiac echo, which I use 100% of the time, and understand the challenges that you may face. So if I can use a publication that was done in 2015, I think, it was done by Sorensen et al. They use certain measurement when you do intracardiac echo. So I want to see the thickness of the septum, the opening of the septum itself. The rigidity, sometimes it can be difficult to determine until you actually a wire across. So when you have a wire across, you can do measurements, and we use this term XYZ measurement, which we can refer in the literature, where the most important part is the opening on the left atrium side. When you have that above 8 millimeters, that usually will give you a hint that you may have residual shunting. In that situations, then you need to understand that you need to choose the right size for the occluder, and you know how to deploy it. The length of the tunnel also plays some role. Usually if it's above 10 millimeters, you make a little bit worry. But the opening on the right, usually I'm not too worried much about it, but you need to know the thickness so you can make sure that your device will seal those paraforaminal valley properly, not just pinning the leaflet. So that's very important features that you need to understand when you do this procedure. So I have a couple of cases that I think it's we can highlight the uniqueness why I use GORE, and also some of the technique that I think is important to understand. So the first case that I want to present is a little bit unique in the sense that it has two features that can be challenging. The first case is a patient who had a long, rigid aneurysmal paraforaminal valley and also a prominent Chiari network. So she's a 36-year-old female without any prior history, unfortunately had cryptogenic stroke at Assad Hospital. And part of the workup, they found that she had a PFO, or paraforaminal valley. But because they also found there's a prominent Chiari networks, they're worried that if they do the procedure over there, it might get caught. And so they refer to our center for the PFO closure consideration. And as part of the workup, as usual, patient with cryptogenic stroke for PFO closure, we evaluated, make sure that she does not have any irregular heartbeat or atrial fibrillation, which she completed. There's no coagulation disorders. And we always have a shared decision-making with the neurologist. So we took her to the cath lab, and you can see this is her pre-procedure TEE, which you can see a long aneurysmal tunnel there. But also, if you can notice there, there is a Chiari network that is flipping around in the right atrium. And that can pose a risk where the device can get caught. So we need to be careful in that situation. So, and when we took her to the cath lab, and this is a pre-ice imaging without wire, and you can see, and then with the wire as well, you can see the Chiari network is close by there. So we were able to cross this, with certain maneuver, and you can see a long tunnel of the paraforaminal valley with the wire across. So is it really rigid? I think there's some rigidity because it doesn't open up that well, but the wire is already there. So we know that's how we assess the significant rigidity. So we decided to close it, and this is post ice with bubble. So the technique of doing this is, number one, you need to make sure that your left disc is deployed left in the atrium, not in the tunnel. And you make sure that you pull firmly, which can make it a little bit uncomfortable, but it's okay. It's actually safe to do that. Then when you want to release the right disc, you make sure that it doesn't catch the Chiari network. Just reposition the right disc and redeploy, and take a look at it through images in the home view to make sure that it doesn't get caught. So as I brought it up before, the flexibility, the softness of that device, ability to accommodate certain anatomy, that's what I really like. Second, and there's no reported erosion. So in this kind of aneurysmal, you'd be surprised sometimes a very stiff device will distort that septum and cause problem in the either immediately or in the future in terms of erosion. And there has been some case report, but I have not seen that with the GORE Occluder. So that's the reason we choose the GORE Occluder. So let's start with the second case that I have here. It's a long tunnel with this time with a thin septum secundum. And this is a 53 years old who's an avid climber, had a stroke symptoms while he was climbing down from Mount Everest at 26,000 feet. He was evaluated at the time, and he was found to have PFO. He was lucky he didn't die, but he came to our center being evaluated for PFO closure. And as usual, no atrial fibrillations. Coagulation tests are unremarkable and recommended by our neurologist for closure. If you can see here, this is the TEE prior, and he was pretty sedated, so you don't see much of the bubble crossing, but these are the features that always make me a little bit worried because it's a long tunnel and a thin septum secundum. Try to engage that can be challenging. And this is the color images that we have. And you can see when on the right side, the left side is after the wire is crossed, but on the right side, you can see the catheter try to engage that. And that's where the key is, try to manipulate your catheter to engage that small, long tunnel, thin septum secundum. This is where certain maneuvers can help you to cross the septum, because it's very important. In order to close the paraforaminal valley, you need to cross the septum first. And one maneuver that I've learned all these years is by doing it counterclockwise. And when you counterclockwise and you engage the tunnel, then you can advance your wire. Then you exchange the stiffer wire, and then you deploy and you bring up your occluder for that purpose. And then one maneuvers that I can share here, and after all these years, that you have to do the same maneuvers when you try to engage the septum by doing it counterclockwise. You can see these images. the counterclockwise there, where you move it counterclockwise, and then as it crosses, you can clockwise to position and make sure you deploy it in the left atrium. So with that technique, when you have a long tunnel rigid after you cross it, you make sure that you deploy your left disc in the left atrium, not in the tunnel, and make sure you pull quite firmly on the left disc against the septum. And as I said, it can be uncomfortable in the beginning, but that's okay. That's the feature of GORE, the flexibility that's not gonna cause distortion of your septum, causing problem, but it will conform to the anatomy. And then with that firm holding, you deploy the right disc and make sure it's sealed properly. And then you make sure that you lock it, you understand the locking mechanism, that you pull enough that the distance is minimized so the lock system can engage. And it's very important not to move your right hand when you deploy this. You hold the handle nicely and then lock through your left hand. The mistake that a lot of sometimes operator will do is they pull everything together and they will unlock the system. So it's very important to know certain maneuvers, and you recognize the locking loop from your x-rays to make sure that this is locked. And then your GORE rep they're very good. They will guide you all those three procedures. That's great questions. I usually try to treat every case the same way, but of course you pay a little more attention when you have this kind of a challenging anatomy. We are talking about long rigid tunnel, but sometimes we also encounter a big long tunnel with big aneurysmal. So in that situation, you have to just think what device you're going to use. You might want to upsize, but you make sure that you do it properly. But I think the key of managing this long tunnel rigid parenchymal valley is your maneuver when you deliver, when you engage, and also your deployment to make sure that you know proper deployment. A lot of mistake is people deploy in the tunnel because they don't notice that, but you need to deploy the left disc so you catch the septum and then really seal it against the septum secundum, not just pinning it down, because that can lead to a residual shunting. That's great questions. Well, number one, my first advice is trust this device. It's a safe device to use. It follows the anatomy, and make sure that you understand your intracardiac echo images really well. If you're not comfortable, you can always get a proctor to help you out. But most of the time, if you follow this step of maneuvering, understand the deployment, the locking, and the last advice, trust your GORE rep. They are very, very good, and they can help you go through this device.